All right, so sharing my screen with you. Things are a bit slow to start today. Perhaps the cold and the wet are getting into that as well. All right, so we're starting off, as I said, with autoimmune hemolytic anemia. And the first thing I'd like you to do, without actually looking at your notes, is to think about what you already know about autoimmune hemolytic anemia and why you think they're being considered in the transfusion science unit. So if I can just have some ideas from people about why you think you're, or what you already know about autoimmune hemolytic anemias and why you think we're looking at them here. Anybody like to put forward some thoughts? What do we already know? Yep, so that's the main difference. Oh, excuse me, hang on, I've just got to clear my throat. So that is the main classification of autoimmune hemolytic anemias, cold versus warm. Yep, so it's in the name really, isn't it? So they're hemolytic anemias caused by autoantibodies. Yep. So why do you think, we've already learned a little bit about them in Heme 2, why do you think we're learning about them in transfusion? Yep. So and how do we do that, Jordan? How do we differentiate alloimmune from autoimmune? So what's the test that we do? DAT, yeah. So DAT tells us whether a hemolytic anemia is due to or immune causes and non-immune causes, really. It doesn't really tell us whether it's alloimmune or autoimmune. It tells us whether it's immune or non-immune. So the reason that we're doing them in transfusion and learning about them is that this autoantibody it can be a real nuisance when we're trying to provide blood for a patient. So we need to be able to remove that autoantibody to see if we can, if there are any alloantibodies that that are being masked by it. So that's really why we're looking at it in transfusion. Okay, so we've got 4 learning objectives in this module, and the main one, apart from sort of defining and differentiating, is really looking at how we investigate an autoimmune hemolytic anemia in the laboratory and the procedure for providing compatible blood for somebody who has autoimmune hemolytic anemia. All right, now I'm just trying to get back to where I was. There we go. So just another bit of a review here. So if you recall from Heme 2, these are all of the tests that we use to detect hemolysis, and some of these tests would be familiar to you because was it last week or the week before, when you actually investigated a transfusion reaction, you actually needed to recall that these tests are also required to do to help us to detect hemolysis. So it's these tests here that give us evidence of premature or abnormal red cell destruction, and as we just said, the DAT tells us whether or not the hemolysis is due to an immune cause or not, whether that be allo or autoimmune cause. So this is a definition of autoimmune hemolytic anemias. So group of heterogeneous autoimmune disorders that cause hemolysis. So heterogeneous meaning that they're many and varied causes, but the thing that they have in common is that they are autoimmune and that they cause hemolysis. So this is when the body's immune system attacks its own red cells, and the patient's red cells are sensitized, and that antibody can, in most cases, be eluted. So the antibody is on the patient's red cells, so the red cells are sensitized, and the antibody can be eluted from those red cells. And so eluted meaning it can be removed from the red cells, or if you like, decoupled from its corresponding antigen on the red cells, and then we can identify it using an antibody panel, the way we do after we've detected an antibody using our screening cells. Now, the thing with these autoantibodies is that they may be present in the patient's plasma as well as being on the patient's red cells, or they may not be. So why do you think we might have an autoantibody that has sensitized the patient's red cells, but it may not be present in the plasma? Why do you think that might happen? Nope. Okay, so the reason that it may not be present in the plasma is because the concentration of the antibody in the plasma may be such that it has attached to the red cells. So all of the antibody that was present, all of the antibody that's been made, has actually attached to the antigens on the red cells. So the red cells are sensitized, but there's no antibody in the plasma. So if there's no antibody in the plasma, then how are we going to tell if the patient's red cells are sensitized? How are we going to tell if there is an autoantibody there, if it's not in the plasma? And the answer is right in front of your nose. Even without doing the DAT, Jordan. So there's only two alternatives there, isn't there? If it's not a DAT, it's not that hemolysis is present, it's this, it's the positive auto. Can you see my arrow on the slide? Or can I only see that? Excellent, thank you, Basim. Okay, yes, so that's how we can tell. If there's no antibody present in the plasma, we can see it from the positive auto in an antibody identification panel. Of course, if there's no antibody present in the plasma, I guess we're not going to have a positive screen, are we? And so in that case, you would do a DAT. And the other thing too is that it may or may not react against other red cells. So it could be an autoantibody that is unique to the patient's own cells. But the thing is, we still need to remove it from the patient's cells and from the patient and identify it. And we need, if it is present in the plasma, we need to be able to get rid of it out of the plasma so that we can see if there's an underlying alloantibody. So these autoantibodies can get quite complicated. So as we already know, because Jordan remembered quite correctly, that the main classification of autoimmune hemolytic anemias is their optimal temperature of reactivity. And so that first subclassification is between warm autoantibodies and cold autoantibodies. And so we divide that into further subdivisions, and so we talk about a warm autoimmune hemolytic anemia, and also most drug-induced hemolytic anemias, the autoantibody that's produced there is a warm autoantibody too. So that's why it's often included under the warm subheading, and sometimes you'll find that it's a separate classification, but because the autoantibodies are usually warm reacting, then it is often included under warm autoimmune hemolytic anemias. And then we have cold hemolytic anemias, and they're probably better known as cold agglutinin disease or cold agglutinin syndrome. And then a further subdivision is paroxysmal cold hemoglobinuria that we will also be looking at today. So you can see here a classification. So we have our warm autoimmune hemolytic anemias here. We have our cold autoimmune hemolytic anemias here, known as cold agglutinin syndrome and paroxysmal cold hemoglobinuria. Something that we will not be considering is mixed autoimmune hemolytic anemias. So this is when you get a mixture of warm and cold, and that's just too complicated. And then, as you can see here, this has been the drug-induced immune hemolytic anemias are separated out here. But that's quite a nice summary of all of them. So this slide looks a bit full, but I wanted the two general types of autoimmune hemolytic anemia on the same slide to make it easier to compare, but also easier to revise. So we'll look at the warm reacting autoimmune hemolytic anemias first, and they are the most common form, and they're responsible for about 70% of cases of autoimmune hemolytic anemia. So this is where our red cells are sensitized with IgG class autoantibody, and it can be either alone with complement, or it can also be complement alone. So we can actually have warm autoimmune hemolytic anemias that are caused by complement. And these ones do tend to be the drug-induced ones. The majority of warm autoimmune hemolytic anemias are caused by antibodies that have a specificity for the Rh system, which is very interesting. Nobody knows why. Most commonly, it's anti-little e, which again is very interesting. And as I said, nobody really knows why. And so any people who have a warm autoantibody, that often it interferes with Rh phenotyping and antibody screening and cross-matching. So they can be quite annoying. So as with a lot of the immune conditions that we learn about, many of them are idiopathic. That means that we don't know why they happen. And these tend to be more chronic cases. And then otherwise they're secondary to other predisposing conditions or to a medication. So when we see drugs there, that means medications. So lymphoproliferative disorders and infections can cause them too. So usually the predisposing conditions are those that affect or involve the immune system. So autoimmune conditions or, in fact, infections. And when we have a look at cold agglutinin disease, about 16% of all autoimmune hemolytic anemia are caused by cold autoantibodies, and so these are IgM and they bind complement. So many healthy individuals have a cold reacting autoantibody, but it's usually fairly low titer, so it's not clinically significant. When we say low titer, it's less than a titer of 64. So everybody, I hope, is familiar with how you titrate plasma or how you titrate antibodies. So we do doubling dilutions, so very similar to the titrations that you would have done in microbiology. So these clinically insignificant autoantibodies are known as benign autoantibodies, as opposed to what we call pathological autoantibodies or clinically significant ones that can actually cause hemolysis. So you can see here that the optimum in vitro reaction temperature for these cold autoantibodies, because they're IgM, is 2 to 4 degrees Celsius. And the benign ones tend to be non-reactive above 30 degrees. So that's the difference between the benign and the pathological ones. That the pathological ones have got a higher thermal amplitude and they will react above 30 degrees. And so what happens is that antibodies attach to red cells in the peripheral circulation, because if you think, you know, even not so much this time of the year, but a couple of months ago in winter, your peripheral areas like your fingers and your toes and your nose and the lobes of your ear, they would get down to around about 30 degrees, certainly a lot colder than your core body temperature. And so what happens is that antibodies attach in the peripheral circulation at these lower temperatures and can activate complement and cause hemolysis. And then what happens, or they can attach in the periphery and then activate complement and detach when they get to the warmer parts of the body, leaving the complement on the cells behind. And so the complement may not be fully activated. It may just be activated to that stage where it attaches to the red cells. And then, of course, the cells are removed by the reticular endothelial system. You can see here that the most common specificity is for the I blood group system on its own or as anti-HI, and there is a P specificity in paroxysmal cold hemoglobinuria in children. And again, the primary cause or the cause of primary cold agglutinin disease is idiopathic. Nobody knows why it occurs, but it is also associated with other underlying disorders, again associated with the immune system, so lymphoproliferative disorders and infections, particularly mycoplasma species and the Epstein-Barr virus, or the virus that causes glandular fever. Okay, so that's the two together. So just an aside here on paroxysmal cold hemoglobinuria. So this is a rare autoimmune hemolytic anemia that can occur following infection in children, very, very rarely in adults. So with children, it tends to be after viral illnesses such as measles, mumps, the influenza, any adenoviruses, chickenpox, cytomegalovirus, Epstein-Barr virus. And then when we're looking at adults, it tends to be more bacterial infections like syphilis, Haemophilus influenzae, and mycoplasma pneumoniae, sorry. So it is a rare condition that is most commonly seen in children, very, very occasionally seen in adults. And the autoantibody that causes paroxysmal cold hemoglobinuria is quite an interesting antibody in itself. It is an antibody that has specificity to the P blood group system, and the P blood group system are usually cold reacting IgM antibodies, but this Doneth-Landsteiner antibody, as it's called, is actually IgG class. So that's really quite unusual, and you can see here that in adults it tends to be again this I specificity and IgM, but this Doneth-Landsteiner antibody in children is IgG with specificity to the P blood group system. And the way that we detect the Doneth-Landsteiner antibody is in the following test that we'll have a look at in a minute. So what happens is that, again, this antibody attaches in the periphery of the body, and then when the cells come to the core of the body at 37, we get intravascular hemolysis and therefore hemoglobinuria. So again, this happens in the cold. And this is how you test for the Doneth-Landsteiner antibody. So you get 3 sets of tubes here. So in tube 1, in each of these sets, we have just patient plasma or patient serum. In tube 2, in each of these sets, we have a mixture of patient serum and normal serum or donor serum. And then in tube 3, we have just the donor serum, so just the normal serum. And there are patient cells in all of these. So the first group of 3, the patient serum, the mixture, the donor serum, they are incubated for about 30 minutes at 0 degrees and then 30 minutes at 37 degrees. And you can see here that there is hemolysis with the red cells and the patient's serum. There is hemolysis, but less so when we have the mixture of the patient and the normal serum and the cells, and we have no hemolysis when it's just the normal serum and the cells. This set of tubes has only been incubated at 0 degrees, and you can see that there's no hemolysis, and this set has only been incubated at 37, so again there's no hemolysis. So it's only in these tubes here that have been incubated first at 0 and then at 37 that we get this hemolysis, and so that's how you detect the Doneth-Landsteiner. Because normally what you would find is if you had an IgM antibody, would you expect to see hemolysis in this group of cells that have been incubated at 0? It's a yes/no answer, and the answer is yes, you would expect to see it because IgM antibodies like to react at that lower temperature, and of course you wouldn't expect to see them. If they were IgG antibodies, then you would expect to see some sort of perhaps a little bit of inflammation there, probably not hemolysis there, because of course the cells are only being sensitized. But it's this group of cells and serum mixtures that are giving us the hemolysis after incubation at both those temperatures, and that's what tells us that we have a Doneth-Landsteiner antibody present, so the anti-P. So then looking at the drug-related or drug-induced autoantibodies, again, we talked about these in hematology 2 as well when we were talking about hemolytic anemias and immune causes of hemolytic anemia. And so if you get a positive direct antiglobulin test, it's always a good idea to consider that it could be a drug-induced autoimmune hemolytic anemia. So how do you think you would determine whether or not it would be a drug-induced autoimmune hemolytic anemia? Where are you, how are you going to find that information? Yeah, patient history. Yep. So you'd either ask the patient if they're on any medication, or ask the ward or the clinic where the patient is whether or not they're on any medication, and that can always help. So anytime you get a positive DAT, you always ask about whether the patient's on any medication. So the mechanisms for drug-induced or drug-related hemolytic anemia, there are 4 mechanisms. I've got a feeling this one was left off your notes, so you might like to add that to your notes. The one down the bottom, drug-induced autoantibody. So there are 4 mechanisms. So first of all, we have the innocent bystander mechanism. So this is where the immune complex is actually formed in the plasma and then is adsorbed onto the red cells. And because that immune complex is now adsorbed onto the red cells, then complement is activated and the cells are destroyed. So that's what we call the innocent bystander complex, where that immune complex is adsorbed onto the red cells. The next one we have is drug adsorption, or the Hapton mechanism. So many of you may know from microbiology that some drugs or some antigens are too small to be, some soluble antigens are too small to be recognised by the immune system, and it's not until they are coupled with a larger antigen, or in this case they are adsorbed onto a red cell, that then they become large enough for the immune system to recognise them. And so this is what happens. So this is, as I said, this is called the Hapton mechanism. So the soluble drug is adsorbed onto the red cells, and then the immune system can see it, and then the anti-drug antibody is produced by the immune system. And of course, because the drugs are on the red cells, then the red cells are destroyed, mainly extravascular hemolysis. So the innocent bystander mechanism is intravascular hemolysis, whereas this one is more extravascular hemolysis. And then membrane modification is really quite an interesting way or mechanism, because the cells aren't actually there's no antibody per se that is made. So the drug is again absorbed onto the red cell membrane, and it modifies the membrane, which allows complement to bind. So it's not an antibody-antigen reaction. So it's non-immunogenic, no blood group specificity, and the eluates are negative. So often with these ones, you can elute an antibody from them, particularly with the drug-induced autoantibody. You can elute the antibody from them, but with this membrane modification, there is no antibody to elute because only complement has been activated. So the the antibody-antigen reaction hasn't actually taken place. So just looking at this drug-induced autoantibody, so methyl dopa, it used to be, it's an antihypertensive that used to be used quite commonly, and then it went out of fashion for a while, but now it's used in cases of refractive high blood pressure. So it is an antihypertensive, but it's not used as much as it was. But it is also used in high blood pressure in pregnancy. So it's used then. And it is one of the most common drug-related drug-induced hemolytic anemias. But it is very interesting in that it is really difficult to tell this apart from a warm autoimmune hemolytic anemia that's not caused by drugs. It's caused by something else. And again, it mimics an anti-little e, an auto-anti-little e, and it also reacts in the absence of the drug. So with all of these drug-induced hemolytic anemias, if you get a positive DAT, then the way to treat this and to get rid of the autoantibody is to cease the drug. And once the drug goes, then the issue disappears as well. But Aldamet is different to that because if you withdraw the drug, you still have this autoantibody present. So it's a real annoyance, this autoantibody due to methyl dopa. So here is a table that I've made for, it's actually I didn't make it for you, Harmoning made it for you. And so here's your mechanisms along the side here, the sorts of drugs that can be involved. And you can see here that the hapten mechanism, the adsorption mechanism, so penicillins, streptomycins, cephalosporins, these are quite common antibiotics. And so they can actually cause drug-induced autoimmune hemolytic anemia. The immunoglobulin class, as you can see, the majority of them are IgG. This membrane modification, it's not an antibody. So there's nothing there to elute, and so the eluate is always negative. With these two, the eluate is often negative as well, particularly with the immune complex one because complement is activated there. And this one here with methyl dopa or Aldamet is the one where we get that the positive eluate. So we actually have an autoantibody that we can elute there. So that's the other really annoying thing with drug-related immune hemolytic anemias is that the eluate is negative. But as I said, the easiest way to deal with that autoantibody is to cease the drug, and then in 3 of the 4 cases, the autoantibody disappears. Now, I'd just like to stop here and have a look at this drug here, which is daratumumab. And again, we mentioned this when we were talking about our plasma cell myelomas in hematology too. So this is the treatment given to people who haven't responded to any other treatments for plasma cell myeloma. So it's sort of a last choice treatment. Now, the thing with this is that it causes pan-agglutination rather than an autoantibody. And so it still causes agglutination in our indirect antiglobulin test, so in our screening cells, and it can still hide an underlying alloantibody, just like these autoimmune autoantibodies. So daratumumab is, as you can see, it's an anti-CD38 monoclonal antibody, and it's used because CD38 is a glycoprotein that is expressed on many blood cell types, and it's highly expressed on plasma cells, so that's why it's used. But unfortunately, it's also expressed on the surface of red blood cells to a varying degree. And really the only thing, or the best thing that you can do, is to actually phenotype the patient red cells before they're treated with daratumumab. And then if they need blood, we can give them phenotype matched blood. If it's too late and they're already using daratumumab, then you need to use dithiothreatol to treat the antibody screening cells and the panel cells. And so the CD38 is destroyed, but the only trouble is that kill antigen complex is also destroyed by dithiothreatol, so you would need to give the patient kill negative blood just in case there was an anti-kill there that you can't now detect. So that's daratumumab. So there are a few things that are making transfusion laboratories' life a little bit complicated, and people being on drugs, and also this daratumumab can cause issues. Okay, just a learning checkpoint here for you. Cold reactive autoantibodies, protein coating the patient cells and detecting the DAT is it C3D, is it IgG, or is it IgM? What are we detecting in the DAT with cold reactive autoantibodies? Come on, have a go, have a go. So Kiani's gone C. Anybody else? So what are we using in the DAT? The direct antiglobulin test. What's the reagent that we use to detect those sensitized red cells? And remember, these red cells have been sensitized. They haven't been hemolyzed, they've been sensitized. So we use our anti-human globulin. So we use our polyspecific anti-human globulin, and then if we get that positive, we then use our monospecific C3D immunoglobulin or our IgG immunoglobulin. So in fact, what we're detecting on the patient's red cells when we are doing the DAT for somebody who has cold reactive autoantibodies is C3D. The IgM has caused it, so the IgM has attached to the red cells, but then it drops off in the warmer plasma, and it's a C3D that is left on the surface, and it's a C3D that we actually detect. Some classes of IgG can. Jordan, if you have a look back when we were talking about the warm autoimmune hemolytic anemias, it's caused by IgG, IgG plus complement, or complement on its own. So the complement on its own is when we're talking about the drug-induced ones, but some classes of IgG, they can activate complement. Most of them can activate complement to the surface level. It's only the Ig plus 3 IgG that can actually cause intravascular hemolysis due to complement activation. Okay, so pathological, clinically significant cold autoantibodies differ from benign cold autoantibodies in A, their antibody specificity, B, their immunoglobulin class, or C, their thermal amplitude. A, B, or C? No, not ready to have a go? All right, that's fair enough. So the answer is They differ in their thermal amplitude. Okay, so cold autoantibodies, apart from PCH, are IgM class. Their antibody specificity, they're usually either of the I blood group system, or they can be the HI combined. So it is their thermal amplitude. So lots of people have got a benign cold autoantibody, but it's because they don't react greater than 30 degrees that they're not clinically significant. All right, and I think this is the final one. Many warm reactive autoantibodies have a broad specificity to which blood group system? A. Duffy, B. Kell, C. Kidd, D. RH. What are the most common antibodies that we find? Yeah. Anybody want anything different to D? Yep, you're right. It's the RH system. Oh, there's another one. Okay, with drug-related autoantibodies, the protein coating the patient's cells and detecting in the DAT is most commonly A, C3D, B, IgG, C, IgM. So as a hint, if you recall that the mechanisms for drug-induced hemolytic anemia have in common that they are complexes that sensitize the red cells. Any advances on A? Any advances on B? Okay, so the common consensus is B, and that is correct. Yep, so most commonly they're IgG with our drug-induced DATs. Okay, so what we might do is just have a couple of minutes break, just so that you can get up and stretch and give your minds a rest. So we'll come back at 12:42. Okay, so hopefully you've been able to get up, do some jumping jacks, get the blood moving to your feet and to your fingers, and we'll now continue. So now we're going to have a look at the pathophysiology of autoimmune hemolytic anemias and relate those to the clinical signs and symptoms that we see. Because, of course, looking at a patient's clinical history gives us a lot of information if we can understand the underlying pathophysiology. So again, I've got warm and cold immune hemolytic anemias side by side, just so that you can see the similarities and the differences between them. And so because warm autoimmune hemolytic anemia is IgG with or without complement, we usually see extravascular hemolysis and the signs and symptoms that go with extravascular hemolysis. Cold agglutinase, on the other hand, can either be extravascular or not either. It tends to be extravascular and intravascular hemolysis, depending on whether that IgM antibody has been able to cause agglutination of red cells and complement activation to the hemolytic stage in the periphery, or whether it's only been able to activate complement to the cell surface stage and then dropped off the red cells. You can see there that cold agglutinin disease tends to be a chronic anemia, whereas the warm hemolytic anemia tends to be acute. And so acute is sort of in quotation marks there, because the onset can be quite explosive, which is classically acute, or insidious, but the hemoglobin can fall to around 50 grams per litre within about 2 weeks. And so in that case, it is quite acute. And so therefore, because we have this sudden drop in anemia, we tend to get these, the classic anemia symptoms of weakness and tiredness. Because cold agglutinin disease tends to be a chronic anemia, you can get the hemoglobin going quite low, but because it reduces over quite a long time period, the homeostatic mechanisms within the body are more able to cope with that lessening anemia. So you don't tend to get the same weakness and tiredness that you get with an acute anemia. But you tend to get numbness, tingling, pain, and cyanosis in the extremities. So what do you think might be causing that, the numbness and the tingling and the cyanosis? So think about what's happening in the blood vessels. If we're having intravascular hemolysis, IgM being a complete antibody. Yep, so you get so what's causing that microvascular damage, Jordan, do you think? Yeah, so not so much clots, but agglutinated cells, just as you see in a tube. So when you're doing your tube tests, you're looking for agglutination there, aren't you? So what happens with cold agglutinin disease or cold agglutinin disease is this agglutination is happening in the microvasculature. And so you're getting a clogging up of the blood vessels, so no blood is getting through, and so you're getting, you're getting ischemia, so you're getting cell death and cyanosis, because there's a build-up of carbon dioxide within the blood vessels. We have splenomegaly in warm autoimmune hemolytic anemia, whereas we tend to see hematuria and hemoglobinuria in cold agglutinin disease. Again, because of the fact that we've got intravascular hemolysis in this case, whereas we tend to have extravascular hemolysis with autoimmune hemolytic anemia. The other thing that you can see here is that warm autoimmune hemolytic anemia can happen in any age or gender, whereas cold agglutinin disease tends to happen in older people. And so that tends to be because it's more commonly caused by, those lymphoproliferative disorders, and they tend to happen in older people. With warm autoimmune hemolytic anemia, if it is due to the underlying disorder, so if it's due to a secondary disorder such as another autoimmune condition, for example, lupus, then there tends to be, it's more common in women than men. So depending on whether it's primary, if it's primary, then any age or gender, but if it's secondary to an underlying disorder, then it takes on the prevalence of the age or gender of that disorder. And so this is an example of peripheral cyanosis. So you can see that the fingers can get quite blue. All right, so now in just finishing up the lecture, so we'll look at the laboratory investigation and also the procedure for providing compatible donor blood. So as we already know, when we have immune causes of hemolytic anemia, we can see these through the FBE, and you can see here we talked about, first of all, the anemia, which can be moderate to severe in both cases. Anisocytosis can also be mild to severe, but it's caused by different things. So in warm autoimmune hemolytic anemia, the anisocytosis tends to be due to reticulocytosis and spherocytes, because remember, we've got IgG antibodies here, which will sensitize the cells, and so we will have the IgG antibody will be taken, if you like, removed from the red cell membranes by the reticuloendothelial system, and hence we get our spherocytes. And because we've got a fairly acute anemia, then you're going to have a reticulocytosis because the bone marrow is trying to replace those red cells as quickly as possible. Anisocytosis in cold autoimmune hemolytic anemia is due to cold agglutinins. So the cells actually are being agglutinated by the IgM antibodies. We do see spherocytosis in both cases, but you tend to see it more commonly in warm autoimmune hemolytic anemia and to a larger degree. Again, polychromasia is due to nuclear and the reticulocytosis, and you also see nucleated red cells too if the bone marrow is starting to get very stressed because it's not able to keep up. So in MCHC, it'll be normal to increased. Again, this is because of the spherocytes. So remember, when you've got a lot of spherocytes, you can get an increased MCHC. And also, we can get an increased MCHC in cold autoimmune hemolytic anemia, and that's again due to the cold agglutinins. And so this is what we tend to see. So warm autoimmune hemolytic anemia, we see lots of anisocytosis due to reticulocytes and spherocytes there, and also we see nucleated red cells if the bone marrow is getting really stressed, whereas in cold hemagglutinin disease or cold agglutinin disease, we tend to see these great aggregates of red cells, which are agglutinated cells. So they're very different pictures. So the laboratory tests that we do, of course, as soon as we see spherocytes, we do a DAT to see if there is an immune cause to the hemolysis. If we do our laboratory test at 37 degrees, which we do with our incubation, we may find that the indirect antiglobulin test or our antibody screen is negative with our cold hemagglutinins. This is because they don't tend to react at 37 degrees. So again, the IAT will be positive with our IgG in our warm autoimmune hemolytic anemia. We will have increase in bilirubin in both cases, but because we've got that intravascular hemolysis with our cold agglutinins, then we will have decreased haptoglobins and hemoglobinuria. So they will be there in cold but not warm autoimmune hemolytic anemia. Of course, anytime we have a positive DAT with our polyspecific reagent, then we need to use our monospecific reagents to see if it's anti-IgG or anti-C3d. tends to be more likely anti-IgG with our warm and with our drug-induced, whereas it was anti-C3d with our cold agglutinin disease. So the treatment in both is treating the underlying disorder if the cause is secondary. So and that tends to, so treating the underlying disorder tends to reduce or remove the autoantibody. Of course, if it's drug-induced, remove the drug. So corticosteroids to help to dampen the immune system, and splenectomy will help with, will assist if warm autoimmune hemolytic is ongoing. But as you might have noticed on one of the slides before, usually with warm autoimmune hemolytic anemia that's due to an infection, it is self-limiting and it will resolve in 2 or 3 weeks' time. It's only if it's due to some sort of an autoimmune condition or some sort of a lymphoproliferative disorder that is more chronic in nature that you may consider needing to go to splenectomy or transfusion. And the interesting thing with cold autoimmune hemolytic anemia is if you keep the patient warm, then the symptoms will subside. And so some patients in Tasmania who have this condition either have to stay in their houses and heat their houses to at least 30 degrees all winter, or they move to Queensland. And so we used to have a couple of patients with cold hemagglutinin disease, and they would just spend 3 weeks or 3 months, sorry, not 3 weeks, 3 months in Queensland in the coldest times of the year. Transfusing patients with autoimmune hemolytic anemia, it's generally not such an issue with cold hemagglutinin disease. I do know one patient that we actually had to do all of our compatibility testing in the 37-degree water bath. So we did our ABO and RHD blood grouping in the water bath. So when you're thinking about your ABO and RHD blood grouping, where do you think the cold autoantibody might interfere? Would it be with the forward group or with the reverse group? It's a 50-50. So think about what we have in the reverse group. Well done, Sean. Yes, it is in the reverse group. So in the reverse group, we are testing our patient blood cells, sorry, our patient reagent cells with our patient plasma. And the patient plasma is where the autoantibody is, and so it is in that reverse group that we can get what looks like agglutination. Well, it is agglutination, but it's not due to any anti-A or anti-B. It's actually probably more likely due to an anti-I. So we get interference with our reverse blood group. So if you do all of the tests, including the patient grouping at 37 degrees, then you can normally, the cold agglutinin will not interfere. Again, because the anemia is chronic, unless the patient is starting to suffer, then you probably, you may not consider transfusion. It really depends on how low the hemoglobin is and what the other clinical signs and symptoms are. A patient with warm autoimmune hemolytic anemia, if it's a post-infection cause, then you would wait for the infection to subside. If it was a drug-induced one, you would remove the drug. So you only really transfuse as a last resort. So with the warm one, the ABO is usually unaffected. The RH, because we use IgM monoclonal reagents, it's usually unaffected. And so with our other reagents, we use the IAT methodology. I don't know why it says AHG, IAT methodology, so that's where it can interfere because they're usually IgG. So the thing is that we do need to remove the autoantibody. to see if there is an underlying alloantibody. Because it is a bit tricky to do that, a good start is to check the medical history, and we check the medical history for any medications to see if it's drug induced, to see if the patient has had any transfusions or pregnancies before, or any other illnesses that the autoantibody could be secondary to. The reason that we look for transfusions and pregnancies is what? Yep, sensitizing events. So it's not so much HDFN because warm autoantibodies can happen in men too. But of course they don't get pregnant, women do. But it's to see if of the likelihood if they're going to have an alloantibody there. So if they've been previously, if they're a woman and they've been pregnant or previously transfused, that increases the likelihood of them having an alloantibody. And of course in men, any previous transfusions increases their likelihood. And so this is, if you like, it's a risk assessment of whether or not the patient is likely to have a significant alloantibody that's being masked by a warm reacting autoantibody. So if they have no history of transfusion, no history of pregnancy, and there you go, no history of a hemolytic transfusion reaction or hemolytic disease of the fetus newborn, then the risk of them having an alloantibody, a significant alloantibody, is low. And you can see that history of transfusion, history of pregnancy, history of hemolytic transfusion reactions or HDFN, as that goes up, as that increases, then that increases the risk of an alloantibody being there as being moderate or high. So you do everything you can to see the likelihood of an alloantibody being there. And so that just, I guess that gives you some comfort as to the risk that is associated with transfusing a patient with a warm autoantibody. But what we need to do is we need to remove the autoantibody, and this is a two-step process. So just going straight on, well, I won't go straight on to the next slide, but the first thing we have to do is to elute the bound antibody from the patient's red cells. And there are three ways that are normally used to do this. The acid glycine elution is the method that's most commonly used because it tends to work best. And the heat elution is used for cold autoantibodies, but you can also use a freeze-thaw method for the warm auto. I'm getting confused. The heat elution method, I don't know why that's got cold autoantibodies there, because you use it for warm autoantibodies as well. You do a cross match at 37 to get rid of autoantibodies, cold autoantibodies. And then you test the eluate for specificity. So if we go on to the next slide, so this is from Harmoning. So in this first sample here, in the first half, this is where we elute the antibody from the patient's red cells. So you can see here that the triangles represent the autoantibody, and you can see that the red cells are coated in that, and also in this case we've also got autoantibody in the plasma, and the red squares here are an alloantibody that's being masked. And so what we do is we treat the cells and remove the antibody from the cells. So this is called elution, where you elute the antibody from the patient's red cells. And then once that antibody has been eluted, what you do is you use the clean red cells to actually adsorb any autoantibody that's still in the plasma, and then you spin down the sample and you remove the red cells, and that should just leave any alloantibody free in the plasma. So that is how we remove an autoantibody. First of all, we elute the autoantibody from the red cells, and then we use those nice clean red cells to remove any remaining free autoantibody out of the plasma. And then you can test the adsorbed plasma for the presence of any alloantibody. It's a fairly fiddly procedure, but it does work quite well. And then you would do a full serological cross-match, and you would use monoclonal IgG just to make sure that you're not picking up any complement that might be left behind. And what you do is you issue what we call the least incompatible units, and you transfuse with extreme caution. So you let everybody know that really you should only be transfusing this patient if they really, really need to be transfused. So autoimmune hemolytic anemias, a group of heterogeneous disorders where individuals produce antibodies to their own red cells. They can be warm, cold, drug-related. They're often associated with an underlying disorder, and we should only transfuse patients as a last resort because giving blood for them can be quite challenging. Okay, there's some review questions for you, and that's the end of this first part of the lecture. So the tutorial this week goes through the elution techniques that are used when we are preparing a patient with an autoantibody for transfusion. So you need to have a look at those methods. So we'll just have a short break now because I notice that we've gone a little bit over time. So if we come back at 1:10, please, to have the second lecture, which is about hemolytic disease of the fetus and newborn. Okay, before we move on, has anybody got any questions about the first lecture? No, no questions? Okay. So I'll just get up my next lecture. Okay, so this is the other thing that we often, we're either usually screening for in the laboratory rather than actually investigating, because hemolytic disease of the fetus newborn is nowhere near as common as it used to be. And again, we've learned quite a bit about hemolytic disease of the fetus and newborn through this semester, and also we learned a little bit about it in hematology too as well. So you can get a bit lost in this lecture because you've got to remember that when we're talking about hemolytic disease of the fetus and newborn, they're the first two things that we're looking at is what happens in the fetus and what happens in the neonate. But when we're looking at laboratory testing and the treatment or management of HDFN, we have to consider the fetus, the newborn, and the mother. Okay, so there's three, if you like, we're looking at through three lenses. So it can get a little bit confusing. So this is just an animation that I like to start off with that I inherited from the previous lecturer. So he developed this. So here we have Megan and Harry, and Megan is RHD negative and Harry is RHD positive, and they meet and they marry and they decide that they're going to have a baby. Unfortunately, the baby has inherited the RHD antigens from the father, and so this is foreign to the mother's immune system. Sometime during the pregnancy, we can have what we call a feto-maternal bleed or a transplacental bleed. And so this is where red cells from the baby enter into the mother's circulation. And if those red cells have different antigens on them to the mother's blood group antigens, then the mother's immune system can be stimulated and antibody can be produced. If that antibody is IgG class antibody, then it can cross the placenta and it can sensitize and hemolysis of the baby's red cells. And so this is what we call hemolytic disease of the fetus and newborn. Most of this should be familiar to you. The thing to remember is that it's not just caused by anti-D, although anti-D was the most common cause up until the 1970s. So maternal alloimmunization, so that can happen anytime during the pregnancy. Usually it's more likely to happen in the second half of the pregnancy, and therefore the first baby is not usually affected if it is an IgG antibody. So the mother needs to be sensitized for the antibody to be produced. So the highest risk of this happening is when the placenta separates from the uterus. So that is usually just before birth or just after birth. So that's the antepartum, or the postpartum or peripartum period. So this is before birth or around birth. So you have got a list and I've just got a picture here. So just to remind you, So this is the uterus, here is the baby in the amniotic sac here, and this part here is the placenta. So the placenta, which is what joins the baby to the mother. So these are the chorionic villi here. So this is a close-up, and it's the chorionic villi that contain the baby's blood vessels. And then here is the maternal side of the placenta, if you like, the maternal interface. And so blood actually enters into the spaces between the chorionic villi. And so into these dark blue spaces here that surround the chorionic villi, and so their nutrients and gases diffuse from the maternal blood into the placenta, into the fetal blood system, and then metabolic byproducts diffuse in the other direction. So at no stage does the maternal blood actually interact directly with the fetal blood unless there is some sort of a hemorrhage along here. So unless the there is some damage to the placenta that damages the chorionic villi, which allows blood into the maternal circulation. So when we look at the pathogenesis of hemolytic disease of the fetus and newborn, it's basically an increase in hemolysis that leads to anemia, and it's that anemia that causes all of the issues. So as we know, normally erythropoiesis and hemolysis, so blood cell production, blood cell destruction, are in equilibrium. If we have an increase in hemolysis, then the bone marrow is able to compensate for that with an increase in erythropoiesis. So we call that either compensated hemolysis or compensated anemia. But still, the bone marrow has increased erythropoiesis, and everything is still okay, even though red cell destruction has increased. We get anemia when the increase in hemolysis actually is greater than the bone marrow's capacity for erythropoiesis. If we have what we call bone marrow insufficiency, where this goes on for a long time, then we get extramedullary erythropoiesis. So we end up with the liver and the spleen reverting back to their previous erythropoietic functions. And this causes enlargement of the liver and the spleen. If the anemia is too severe and goes on for too long, then we end up with tissue hypoxia. So we don't get proper perfusion of the tissues. This affects the heart and the liver most. And so we end up with issues around heart failure and liver failure. So we end up with venous hypertension because the heart's not pumping properly. Therefore, our venous return isn't sufficient, and we get this pooling of the blood in the venous circulation, and that's what we call hypertension. Because we have liver failure, we have hypoalbuminemia, which affects the osmotic concentration of the blood, and so we don't get proper return of fluid from the tissues, and this ends up in a condition called hydrops fetalis. Now that term hydrops fetalis literally means watery fetus. So the fetus is full of fluid. So the fluid is in all of the extravascular spaces rather than actually being in the blood vessels. So the consequences leading to hydrops fetalis, again, as I said, a heart failure and hypoalbuminemia, causing venous hypertension, and this is where we get our abdominal swelling and our pulmonary edema. So we get fluid within the abdominal cavity, fluid within the thoracic cavity, but also fluid within the cranial cavity as well. And we also get an increased amount of amniotic fluid, so you get a large placenta as well. So our poor little baby can have a swollen head, swollen chest, swollen abdomen as well. They're literally full of fluid. So that is in the fetus. If we have a look now what happens in the neonate, so once the baby's born, we need to remind ourselves, first of all, what happens normally in red cell death or in hemolysis. And so we have first of all, most hemolysis happens in the spleen, so we get the erythrocyte is lysed and the hemoglobin is broken down to globin and heme, and the heme is further broken down to unconjugated bilirubin, which then is dealt with in the liver. And then conjugated bilirubin, so water-soluble bilirubin, is then used in bile and is excreted through urine and feces. So what happens in increased hemolysis is because the spleen is more active, the spleen gets larger, so we end up with splenomegaly. Because the liver is more active, we end up with hepatomegaly. And because the amount of bilirubin being produced, the amount of unconjugated bilirubin being produced is too much for the liver to cope with, we end up with jaundice. So neonates usually have immature organs as well, so immature spleen and immature liver, so that doesn't help with dealing with the additional hemolysis either. So it's this jaundice that's really the issue. So why do we get jaundice in a neonate, but we don't get jaundice in a fetus? Again, this is image from Harmoning. So the consequences of increased hemolysis, antenatal versus neonatal. So in the fetus versus the neonate. So in the fetus, first of all, we have, this is the fetus here, so we have increased lysis, but the bilirubin is able to cross the placenta and be dealt with by the maternal liver. Once the baby is born, however, they lose this connection with the mother, and because their liver is immature, it can't deal with all of the bilirubin, and so we get hyperbilirubinemia. So this still results in jaundice and something called kernicterus. So kernicterus is when we get this quite high levels of bilirubin. Now remember, this is direct bilirubin, it's unconjugated bilirubin, it is fat-soluble bilirubin, and that's why we get the jaundice, because fat-soluble bilirubin dissolves in the subcutaneous fat under the skin, but worst of all, it also dissolves in the tissues of the brain, because there is a lot of fatty acids in brain tissue. And so we can get what we call bilirubin encephalopathy. So this can lead to subtle or severe effects and neurological problems. So we can have developmental delay, or what's called bilirubin-induced neurological dysfunction, mild mental retardation, and kernicterus is the more serious form. And so this is where we get a lot of bilirubin being deposited in the brain, particularly in the basal ganglia. And so we get what we call lesions in the brainstem, and this can happen in the auditory centres, the oculomotor centres, or in the vestibular centres. So we can have quite serious side effects from these hyperbilirubinemia. And so we try very hard to make sure that that doesn't happen. And I think that should be a fairly straightforward learning checkpoint for you. The important difference between the fetus and newborn physiology is bilirubin metabolism, maternal antibody level, or the presence of anemia. Yes, of course it is A. Well done, Poppy. Okay, relate the following clinical signs and symptoms to pathophysiology of HDFN in the newborn or the neonate. So if they've got trouble breathing, what's that related to? Yep, pulmonary edema and jaundice. Yep, liver, well done, Bassem, and swollen abdomen. That one's probably the hardest. Yep, so low albumin, so hypoalbuminemia, but also we would have the heart failure, which is causing the venous hypertension as well. So there's two things that are causing that. Well done. Okay, so now looking at the laboratory testing. So laboratory testing has a number of functions and are done at various stages throughout the antenatal period. So the antenatal period is when the mother is pregnant. And so in this screening, we're screening of the mother and the fetus to make sure that both are well and healthy. So in Australia, most people are all encouraged to go along to their GP at least at 12 weeks gestation. So usually once you find out you're pregnant, you toddle off to your GP and say, hello, my pregnancy test has come back positive. You know, my last period was blah. So then, you know, then the doctor can work out how pregnant you are, and you can as well, and when your baby is due. And so from then on, you would have a routine test at 12 weeks gestation. So and this is a list of tests that you would do. And the one that we're mainly interested in the transfusion laboratory is this blood group and antibody screen. So what we're looking for here is still very much whether the mother is RhD positive or RhD negative, but also the ABO blood group as well. And the other thing that is quite useful is the ultrasound, looking for high amounts of amniotic fluid. But the ultrasound is not all that useful for at 12 weeks gestation because the fetus is too new, too young. And but ultrasound later on in pregnancy is very useful just to check and make sure that there's not a lot of amniotic fluid or placenta, or that the baby has not got a lot of fluid. And also regular maternal monitoring and fetal monitoring to make sure that both are fit and well. If the other thing that you saw that was done there is ABO and RhD blood group and antibody screen. Yes, we do an antibody screen there as well. And so, of course, that is looking to see if the mother has already got an antibody. You know, she's already been sensitized and produced an antibody. And so we call this a positive antibody screen. So, of course, we have to identify the antibody. And the other thing that we do is we do a phenotype on the mother's red cells, the father's red cells as well, to see if the father happens to be carrying the corresponding antigen to the mother's antibody. And these days, fetal genotyping is being done more and more because it can be done quite non-invasively. And the way that they do it is that they can actually isolate fetal DNA from maternal plasma, which is pretty amazing when you think about it. So not only can we get, you know, feto-maternal bleeds, but we can get fetal DNA, free fetal DNA that crosses the placenta. Because it's so small, of course, it can just cross the placenta, do anything to the mother. It's the red cells that are the problem with the immune system, not the DNA. But it is a really clever way of being able to obtain fetal DNA that you can then genotype. And so more and more these days, if they find that the fetus does not carry the corresponding antigen to the mother, then they don't worry too much about it. But of course, if the fetus does carry the corresponding antigen, then that's a different kettle of fish altogether. So if fetal genotyping is not possible, it could be, you know, that the technology is not available to the laboratory, then what they will do if they do find an antibody in the mother's plasma is that they will do an antibody quantitation. And traditionally, again, this is done by titration, by titrating the antibody. So again, we do make doubling dilutions of maternal plasma in buffered normal saline, and then we react a couple of drops of each of the dilutions with cells that are homozygous for the corresponding antigen to the mother's antibody, because we want the cells to be able to detect small quantities of antibody. So that's why you use homozygous cells. And then we titrate the antibody. You can use more specific and precise methods such as RIA, ELISA, and flow cytometry. But again, quantitation is often still done, and it may be that it's sort of done as a screen, and then you head off for flow cytometry after that. So not only do we do it at baseline when we first identify that the mother has got an antibody, but the mother is then monitored throughout the pregnancy to see if that antibody concentration increases. And so we notice an increase in the antibody concentration by an increase in the titer. And that increase means that the mother's immune system is being stimulated, and that is most likely due to the fetus having the corresponding antigen. So you can see we do it initially at 12 weeks, and then at 16, 20, 24, and 28 weeks, and then 2-week intervals after that. If we do see an increase in the antibody concentration, then a fetal ultrasound is carried out, but it can only be done at 16 weeks. It can't be done any earlier than that. And the way they do it, again, is really, really clever. It's a non-invasive way of doing it, and they use a Doppler ultrasound, and they check what's called the peak systolic velocity of blood flow through the middle cerebral artery in the fetus's brain, this artery here. And so if the flow of blood through there is related to the viscosity of the blood, and the viscosity of the blood is related to the amount of red cells that are in the blood. So if you like, the thickness of the blood, the viscosity of the blood. If the blood is thin, so i.e. it doesn't have a lot of red cells in it, it flows through the artery faster. If there is normal amounts of blood in the artery, then it will flow through slower than if there is less. Okay, so that's just such a clever way of doing it without having to, you know, to intervene or interfere with the baby. And then if it's found that the baby is anemic, so this MCA PSV it's called, or fetal ultrasound, if the baby is found to be anemic, then we can do what's called cordocentesis, and we can take a little bit of blood from the umbilical cord and actually check what the hemoglobin is. So that's what we do during the pregnancy for the mother and for the fetus. Once the baby has been born, then what we do is we can do a cord blood testing. So again, when the baby is born, when the umbilical cord is cut, they can take a blood sample from the umbilical cord that they can then test the ABO and RHD blood group on the baby and do a direct antiglobulin test too, if necessary. So all infants of RHD negative mothers do have their cord blood screened. They do an ABO and RHD group. So if the baby is found to be RHD positive, then they would do a direct antiglobulin test. So this is done on RHD negative mothers, and as you can see, they're infants that have postnatal jaundice. So they're either born with jaundice or they develop jaundice within the first 24 to 48 hours after birth. No, cordocentesis is the same as cord blood testing. Well, it sort of is, but it isn't, Kiani. I guess it's a matter of semantics. So cordocentesis is done, really refers to the fetus and withdrawing blood from the umbilical cord from the fetus, whereas cord blood testing is done on the neonate. So while you're sort of taking blood from the same place, you're doing it at different times, if that makes sense. Good question. Now, it's really important before you do an ABO and RHD blood group to wash the cord blood cells very well to remove this stuff that's called Wharton's jelly. And it can cause one of our ABO discrepancies if we're not really careful. And so what Wharton's jelly is it's a mucus connective tissue. So what it is sort of like a packing in the umbilical cord that helps to protect the fetal blood vessels. And so we need to wash the cells very thoroughly to get rid of this mucousy substance. Otherwise, it will cause panagglutination. If our direct antiglobulin test is positive, again, we need to elute the antibody from the baby's blood cells and identify it. And usually if we find if a positive DAT on the baby, then we usually have an antibody in the mother. And so we need to identify the antibody off the baby's blood cells and also in the plasma of the mother. We need to determine the phenotype of the mother, the baby and the father to make sure that everything matches up and to help us to identify that antibody. All right, so what are the blood groups that are implicated in hemolytic disease of the fetus and newborn? So we see here, I've got this slide up just to make you aware of the fact that there are a number of causes of hemolytic disease of the fetus and newborn. Some of them are immune and some of them are non-immune. But because we're in transfusion, we're really only interested in the immune causes here. But just bear in mind that there are other causes as well. The more severe causes of hemolytic disease of the fetus and newborn are the Rh antibodies, particularly anti-D. More frequent but less severe is HDFN caused by ABO incompatibility. Yes, you can get ABO IgG antibodies. And we'll talk about those in a minute. And then, of course, we can get ABO HDFN due to other clinically significant antibodies of IgG class. And so there are more than 50 different antibodies that have been implicated in HDFN, and their frequency varies depending on the ethnic group. So we've got ones that are commonly involved, ones that are rarely involved, and ones that are never involved. So why are these antibodies never implicated in hemolytic disease of the fetus and newborn? Exactly, because they're IgM class antibodies. These ones rarely do. We've got a bit of a mixture of IgG and IgM in those ones. And these ones are very common. Notice this table does not include HDFN due to ABO incompatibility. So this table lists the antibodies that are associated with HDFN in Caucasian populations. In other ethnicities, the prevalence changes. So, for example, in Asian populations, the frequency of RHD negative people is so low it's not funny. I think RHD positive people occur in about 99.99% of Asian populations. So anti-D is just not an issue. In fact, in one review of antenatal visits to a centre in Hong Kong, so these are the ones that are most commonly in Caucasian populations, but these ones that were in a review from people with positive antenatal screens in Hong Kong, so anti-Big E was 19.7%, anti-Big S was 10.6%, and anti-little c was 7.6%. So it very much does depend on your population with HDFN. So as you can see, the famous 4 case antibodies that are involved in HDFN are also the antigens most likely to elicit an immune response. Although you may have noticed that little c and kel are transposed here. And that could be something to do with the fact that So we go back to here. You can see that little c is second, anti-little c is second, and anti-kel is third, and that could be something to do with the prevalence of K positive, big kel positive individuals. So these are the 4 most immunogenic antigens, and they are the 4 that are most commonly implicated in non-ABO hemolytic disease of the fetus newborn. Now, I need to talk about the Miltenberger phenotype here. We haven't learned about the Miltenberger phenotype before, but it's a variant, as you can see, of the MNSS blood group system, and it's quite a complex subgroup consisting of 11 antigens and 11 phenotypes, and each of those phenotypes has been shown to express from 1 to 6 antigens. So as I say, it's quite complex system. It's very rare in Caucasians, but it's very common in Asian populations. So Chinese, Thai, Philippine, Indian, Malaysian, Japanese, Sri Lankan individuals. And the most clinically significant antibodies are anti-MUT or anti-MUR. However, again, in that same Hong Kong study that I talked about before, just over half the women who carried an atypical antibody had an anti-MIA. So these 6 are the most clinically significant, and they've been involved in hemolytic transfusion reactions and HDFN, but it's these 3 that seem to be the most common. Now on to ABO HDFN, and since RHD negative maternal prophylaxis, and that's what we'll have a look at in a minute, our ABO HDFN is the most common form. It's very rarely severe, it's usually fairly mild, and it's usually dealt with quite easily by exposing the baby to sunshine, and the sunshine is enough to resolve the jaundice. So usually it's group O mothers with group A babies, but sensitizing history is irrelevant. Why is that? So remember, sensitizing history is the mother having had a transfusion or the mother having had a previous pregnancy or a feto-maternal bleed. But sensitizing history is irrelevant when we're talking about ABO HDFN. So what normally is the class of antibody for ABO antibodies? Come on, you know this. Yeah, they're usually IgM. Well done, Sean. IgM antibodies are most commonly what we call innate or naturally occurring antibodies, and so they are there. Remember, if you are a group O mother, you're going to have anti-A and anti-B in your plasma, regardless of whether you've had a transfusion, regardless of whether you've been pregnant before. And so you will just have it. So if you have a group A baby, you've already got anti-A in your plasma. Most of that anti-A is IgM, but some of it is IgG. And so some of it can cross the placenta. So you see, intravascular hemolysis is quite rare, so it tends to be, you know, the cells are sensitized, and we usually, it doesn't affect the fetus. Again, it's the neonate. Once the baby has been removed from the mother and all of the mother's supporting organs, if you like, and the baby is on its own, that's when we tend to get the bilirubinemia. Very rarely do we get severe cases. So these are characteristics of ABO versus RH, hemolytic disease of fetus newborn. So you can see first pregnancy, yes, we can get ABO incompatibility. Very rare with RH, it tends to be second and subsequent pregnancies. Okay, so now looking at the treatment and management of HDFN, and we need to look at the mother, the fetus, and the newborn once again. So this comes from a paper from 2015, and it shows the remarkable effect of anti-D prophylaxis. In fact, I think the person who discovered that this actually worked won a Nobel Prize, because you can see before the introduction of anti-D prophylaxis, there were, in the 1950s, there were over 1,000 babies born per year, or 1,000 babies who were affected by hemolytic disease of fetus and newborn every year. And since the 1970s, that has dropped right down. And so now it's currently, you might have 15 to 25 deaths per year. So there are a lot of babies' lives have been saved, and the mothers as well. So what prophylactic anti-D is it's antibody that has been raised in Rhd negative blood donors who allow themselves to be sensitised against anti-D. And there are currently about 130 Australians contributing to the program, and many of these people donate plasma every 2 weeks. They're usually male or women who are past childbearing age. But to maintain their anti-D levels, they receive regular boosting injections of Rhd positive cells, and these are from donors who have been extensively screened and carefully matched. So not only do we have people who donate their plasma, and the anti-D is then harvested from their plasma, but we've got the donors who provide the boosting red cells that are also part of this program. So because of, since the introduction of anti-D, or prophylactic anti-D, also called Rhd immunoglobulin, since the introduction of this prophylaxis, the most common cause of HDFN is anti-A in group O mothers, anti-K, anti-little c, and anti-big E. So this Rhd prophylaxis is given to Rhd negative women with no preformed anti-D. And so it is anti-D antibody that we're giving them. And what happens is that if there has been a transplacental bleed, so if some of the fetal red cells have gotten into the mother's circulation, then this anti-D attaches to those fetal red cells, and then the maternal spleen will lyse them and get rid of them. And so the immune system of the mother has not been stimulated. So it's really very, very clever. Routinely in Australia, the Rhd immunoglobulin is given at 28 weeks to all Rhd negative women, and 34 weeks, and then at delivery. If there are any sensitizing events, so if there's anything happens that some sort of abruption or damage to the placenta at any stage during the pregnancy, then it will be given as well. But it's routinely given first at 28 weeks and then at 34 weeks. So it's just really clever the way it works. It doesn't affect the baby, and it stops the mother's immune system from being stimulated, but we only have Rhd immunoglobulin at the moment. So the Kleihauer test is a test that actually quantitates when a transplacental bleed does take place, and we need to know this because we need to know how much anti-D immunoglobulin to give. And the principle of the Kleihauer test is the fact that fetal hemoglobin, so hemoglobin F, you may recall from hematology 2, we have hemoglobin F, and we also have hemoglobin A, adult hemoglobin. And so hemoglobin F is more resistant to acid elution than adult hemoglobin is. And so basically a sample of the mother's blood is treated with this hematoxylin ferric chloride solution, and adult hemoglobin is eluted. Hemoglobin A is eluted from maternal red cells, whereas the fetal hemoglobin remains within the cells. Okay, hemoglobin F remains within the blood cells, the baby's blood cells, it's not eluted. And then it's counterstained with eosin, and so the maternal cells come up looking very grey, and the fetal cells are pink because the hemoglobin has stayed within them and it's been counterstained with the eosin. And so these days, this is really done as a screening test, and then if a fetal and maternal bleed has in fact happened, then the sample will be sent for flow cytometry so it can be properly and more accurately quantitated, and then the amount of RHD immunoglobulin that's required can be given to mop up all those fetal cells. So a fetus affected with hemoglobin disease of the fetus newborn, again, so this is with a mother who already has an antibody, so that antibody titer is very closely watched, and the baby will either be delivered early or given an intrauterine transfusion, which is pretty amazing. What we can do to the fetus these days is just amazing. I mean, operations are not routinely undertaken on fetuses these days, but certainly far more than they ever used to be. And so we can tell how stressed, if you like, the fetus is by doing the Doppler ultrasound on their mid-cerebral artery to find out how anemic they are, and then we can either deliver the baby early or do an intrauterine transfusion. So in the past, affected babies would be induced after 24 weeks, but these days we try and keep the fetus within the mother as long as possible, because of course that allows the baby to develop and grow. And so you can see here that an intrauterine transfusion can either go through the umbilical cord, so this is a per umbilical transfusion, or the blood can be introduced into the peritoneal cavity of the fetus, and then it's absorbed into the bloodstream from there, which is pretty amazing, really. So what's shown here is it's being directly into the umbilical vein. So when we are selecting blood for intrauterine transfusion, what group of blood are we going to be selecting? So we use packed red blood cells. So are we going to use blood that is compatible with the mother, blood that is compatible with the fetus, or a particular blood group? And the answer is group O. We use group O packed red cells. And of course, the reason we do that is because there are no ABO antigens on those red cells. We also, if the mother has got an antibody, which usually they do, we make sure that the cells that are transfused to the fetus are negative for that antibody. We make sure they're CMV negative because we don't want to give cytomegalovirus to the baby. We also irradiate them to kill off any lymphocytes that might be there. Make sure it's fresh so that we don't introduce any increased what we call blood storage lesions, you may recall. And we also make sure it's warm to 37 degrees because, of course, the fetus is at 37 degrees. So if we need to deliver the baby early, then we need to treat the neonate. And of course, we need to remember that the neonate has an immature liver, and so it's not going to be able to deal with the bilirubin, and of course the baby is also anemic. And it's also because the liver is going to be immature, it's going to have hyperalbuminemia as well. So there's a number of things that we need to deal with here. And the way that we do them is, first of all, we want to reduce or remove the unconjugated bilirubin, and we do that through phototherapy. And we want to increase or replace the serum albumin. We want to remove or reduce the concentration of the maternal antibody, and we want to increase the neonatal hemoglobin. And we can do all of these things by an exchange transfusion. So exchange transfusions are done very rarely these days. We tend to do intrauterine transfusions instead. Phototherapy, this is what a friend of mine used to call Club Med up at the QV. So these are little babies who have got jaundice or hyperbilirubinemia, and so they're put under lights, at have a wavelength of ultraviolet light, wavelength of 425 to 475 nanometers, and that UV light helps to convert unconjugated bilirubin in the fatty tissues of the skin to the soluble conjugated form. And it's known that the intensity of the light is inversely related to the distance from the light source. So you can now get fiber optic blankets you can actually wrap the babies in, but you need to be very careful that you don't give them sunburn, and you need to shield their eyes, which is why my friend used to call this Club Med, because it looked like they were sunbaking with white sunglasses on. Exchange transfusion. We've already looked at exchange transfusion as a special case for compatibility testing. So again, we introduce donor blood, and also you can introduce plasma as well into the baby and remove waste blood. So you take sort of 10 mils out and put 10 mils in. And so you can actually do a full body exchange this way. So it, as I said, increases hemoglobin, dilutes the maternal antibody, and also dilutes the bilirubin, and also increases the albumin concentration. So it does quite a few things. And again, the blood that we use here is group O packed cells, which is antigen negative for the maternal antibody. So there are a number of complications of exchange transfusion, and a number of these around the the cardiac and the metabolic effects of giving a transfusion. I'll let you read through those on your own. So again, we have a summary for you and a number of review questions that you can practice answering. Okay, and again, we've gone a little bit over time. I do apologise for that, but you still have 4 minutes before your next session. If you have a session starting at 2 o'clock, has anybody got any questions about the second half of the lecture today? No, no questions? Okay. Well, in that case, it's been a pleasure giving you lectures. So don't have any more face-to-face sessions. You do, however, have a prac exam in week 14 before your prac exam the following week. So thank you very much for being a part of this unit and for being so proactive and active in the interactive sessions. I've really enjoyed it, and I hope you have too.